Good morning, everybody. Good afternoon to colleagues from India and other parts of the country. It's a pleasure to welcome you to JBI gLocal, our first event. We co-hosting with the Medical Service Center in Calcutta, India, and the CPHR month also from Calcutta, India. It's a pleasure to us. So we are just giving few minutes for people to join us, and we will start our session in next few minutes. May I request our co-chair, Dr. Bigan Bera, to come online, and we will be going live in next few minutes. Thank you.
Welcome all. My first webinar, disaster medicine and psychological first aid lesson learned from India and South Africa. Today, 2005, organized by Ekurhuleni Clinical Research Center for Health and Research, JBI affiliate India and Medical Service Center India. National Medical College is the first medical college in Kolkata. Was the aspiration.
We cannot hear you properly, Dr. Bera. Can you please be a bit come closer to the mic?
Yeah. And now can you hear? Is it all right?
Better now.
Yeah. Calcutta National Medical College is the first medical college in Kolkata that was created through the aspiration of our revolutionary freedom struggle.
Can I please request other people to switch off the video and unmute themselves? And can they please remove their other gadgets such as the phone, because phone they can disturb the audio here. Thank you.
Beside college academics, other engagement, lack of engagement, other engagements, some of us stumble upon a search for unanswered question. Actively involved in understanding the health challenges of our country in multiple dimensions. The different disasters like Bhopal gas disaster, Jabalpur earthquake, and other floods and floods throughout the country in different states, we observe. Observing the multiple dimensions of health in a dynamic state, not a static entity, the normal time, most unstructured time of disaster, where one is challenged to put all one's knowledge, emotion, and commitment to practice. Welcome all. Be happy. Learn from the pioneers, holding high standard of medical ethics, and let world not profit but be a better place for all through knowledge. Thank you all.
Thank you, Dr. Bera. So we'll now start showing the video from the JBI Adelaide, Professor Joe Jordan. Just give us a second. We are just switching it off. Thank you. Sorry, we had a challenge with the audio. We'll play during the break time, the video. Let me take the pleasure to introduce Dr. Jayati Kushari Basu from JBI Ekurhuleni Center. Please go ahead and introduce the center that you are affiliated to.
Thank you. Can I please share my slides here? So I have only 3 slides, so I won't take long time. Good morning, everyone, and good morning, whole world, and thank you very much for attending. So there are about 8 JBI centers in African region, in Ghana, Ethiopia, Kenya, Cameroon, and South Africa. Our center was established in February 2023 under the auspices of University of Pretoria, and our administrative head, University of Adelaide, Australia. Ekurhuleni Center was the second JBI center in South Africa. There is another center in South Africa and number 8 in Africa. Our center is run by very few, but over-enthusiastic volunteers and our valuable administrator. And we are all here in our center. You can see how very few members are running a center quite successfully. And they are all working elsewhere, but they are putting their time and effort to run the center whenever something we need to do. The main aim of our center was to practice evidence-based healthcare in the area of maternal, child, and women's health by implementing evidence into the practice. Our center is mainly focusing on maternal and child health, but our volunteers included from various disciplines. So we actually engage ourselves in various other themes and topics. Our activities included hosting symposium, conducting journal clubs, conducting scoping and systematic reviews, and we also participate in various University of Adelaide, the main center, JBI's activity. And our future plan so far is to start training on the JBI methodology and publishing systemic and scoping reviews, which we are still actually working on in our pipeline. Thank you very much.
Thank you. It's my pleasure now to introduce the second speaker, who will introduce us to the JBI CPHR, Dr. Nirmala Mukherjee, who is the director for Manbhooms Ashram Nityananda Trust, or MANT, in Calcutta. Dr. Mukherjee is a trained and professional social worker. He has a master's in public health and PhD in mass communication and journalism. He's currently the director for this center, which is the JBI affiliate, and he has attended several courses from many other universities and more than 23 years of experiences. I don't want to give up his age because he looks a very young man still, although he has so many years of experiences, and he conceived and designed and managed and evaluate health and development projects in various capacities. Over to you, Dr. Mukherjee.
Yeah, thank you, sir. Thank you very much for your, this kind of, introduction, generous introduction. So I should request my colleague, Dr. Sajida, to share the, screen, the presentation. Sorry, I'm out from, country. So that's why I need the support from Sajida.
Thank you. Thanks a lot for joining.
Yeah, so Center for Public Health Research at MANT is basically, the research wing of MANT. So MANT is a development organization established way back in 1960. And we have been working in 6 verticals. So one is education, one is health, one is community media. So we have been running community radio station, community video station in tribal languages, then livelihood promotion program, then climate action, and obviously research. So we are basically covering the entire eastern and northeastern parts of India with 116 trained and experienced staffs. And our primary focus on indigenous development, and it is a mandate for MANT that 3 people from the tribal community should be the member of our executive committee. So we have been touching more than 1.5 million lives every year. And the CPHR is basically the research wing, what I have already told you, that that has been conducting various primary research, systematic as well as scoping reviews. And we are basically experts in health economics with support from various national as well as international academic and research institutions. So our team is a multidisciplinary one. So we have 4 PhDs, 7 postgraduates, and 4 field investigators. Next. Next. So our research areas is basically covering environmental health, health technology assessment, mental health, One Health, tobacco control, tribal health, and evidence synthesis. We are basically focusing on One Health and tobacco control right now, along with tribal health at this point of time. Next. So we are a JBI affiliate center, and the center is basically working on specific health needs of the India's indigenous population, the most marginalized section of the society at the contemporary India, and they have a unique healthcare needs, cultures, and customs, and the social system is completely different. from a from the general population, and they have been suffering from the quadruple burden of diseases, as you all know. So we have been focusing on intersectionality, equity, and evidence synthesis and implementation. So this centers works to generate the necessary evidence to bridge the healthcare gaps between indigenous and non-indigenous population. Next. So CPHR is the National Center for Research on Tobacco Taxation, supported by Vital Strategies. It has also been developing a tool for tobacco control enforcement in 5 states in India. And we have started working as a regional institute for capacity building and training under NACO. Next. We are also the doctoral training center with affiliation to Manipal Academy of Higher Education. Next. And we have been covering almost pan-India kind of implementation of research programs. Next. So thank you.
I'm introducing Dr. Torun Mandal, our founder member of Medical Service Center, Vice President, Medical Service Center. We will talk about our organization, and I welcome him to start with his speech. Thank you very much. Good morning and good afternoon here in India. As you knew already from Dr. Vigyan Bera, that Medical Service Center is a voluntary organization. All the members are volunteers over here. It's a socio-medical organization and working since 1977. I was in the first year of my MBBS curriculum, medical college, Constitution, medical college.
This one, yes.
Am I audible, I think?
One is not present.
Yeah, Chairman?
Yeah.
I'm audible, I think. Should I continue? Right.
Yes, you are very much audible. Thank you.
So, Medical Service Center, before starting, thank you very much. With a bunch of medical students who started our work. And before going to that, we wanted to fix up what is the health challenges in India and how we can reach health facilities of the remotest marginalized people of India, and particularly to stand by them, the hapless people during the time of disaster, distress, and deprivation of health, and to raise consciousness of the people to take health as their health right, and also to follow the medical ethics as per the footprints of our pioneers. And to do that, we had to rally all concerned people who are wishing to work for the upgrade of health of the people. And as a part of our struggle on the anvil of medical ethics, we had to preach and demand that health should be a fundamental right of people, and it should be delivered, no other, totally by the state from the primary level to the tertiary level. And we have to inculcate from our medical curricula in our profession. In this course of our activity, we had to pass through different disasters we have faced during our student life, and after passing out professional service, private professional practices. We worked in different states of India. We are now spreading in around 20 states and 3 Indian territories of India. And during floods, during earthquakes, during cyclones, super cyclones, during riverbank embankment breach, Bhopal gas disaster like worldwide famous poisonous gas disaster, in all kinds of disaster, wherever it was, tried to send our pre-medical team and tried to respond to the first medical response of any disaster event. Even in man-made disasters, like say Babri Masjid demolition, is a famous incident in India but all over the world. After the incidents of Nandikam Singhu, the land grabbing by the in collaboration with the government by the multinationals, and even such accidents while in the hospitals, some bridge collapse, railway accidents like such patients. And you can see the slides and etc. And it place our demands to the government. Also, we raised several times to the we demanded to the Minister of India, where all kinds of publications you can see in the banners of the pioneers, Albert Einstein, Samuel Hahnemann, all the pioneers there with the same. So these course of works during this nearly last 5 decades, nearly 5 decades, we are crossing 1977, we could learn that not only the delivery of medical service, we have to stand by them for their psychological problems also, and particularly providing them psychological first aid, particularly during the times of riots, the times of Babimo's demolitions, some other times at the Sainbag in Delhi slums, recently in Manipal, and after the Nandigam, uh, recently in Manipur, the state of India, assistance, and in several times like pandemics, COVID, Corona, even in regular courses, juvenile diabetes, and when even in the hospital cluster, when the patients and the relatives are freed, and to prevent particularly the post-traumatic disorder, we had to learn, we had association and cooperation and teachings from our psychiatrists, from our psychological counselors, from the basic primary knowledge we have got in our medical curricula. We had been driven, and we could learn that psychological first aid is a very important part of any disaster management, or even during any regular service to the remotest portion of the we had to reach help the marginalized people. We inculcate medical ethics in medical curricula that we are wanting. We are following the pioneers like Norman Bethune, who told that redefine medical ethics, not as a code of professional etiquette between doctors, but as a code of fundamental morality and justice between medicine and the people who called for doctors, go to the wounded, don't wait the patients, the wounded to come to you, and you follow the great scientists like Albert Einstein. 100 times every day, I remind myself that my inner and outer life depends on the labors of other men, living and dead, and that I must examine myself in order to be the same measure as I have received and still the same. Hope and believe that the whole international community for this ethical approach, ethical fraternity, stand and hands sufficient justice, deprivation.
Again, a good day to everyone. Thank you, Dr. Mandal, for sharing such a good insight on the Medical Service Center. And we really appreciate and thank Dr. Bera for my co-chair. Now we are moving to session 2, but just let's take a 5-minute comfort break because that session is extremely important. We are going to look out now on the some of the disaster. So may I propose that we take a few minutes break. We'll be back at 10:35 South African time or 14:05 Indian time. And then may I request my co-chair, Dr. Anshuman Mitra, to take over from there.
Yeah, I'm here.
And just to check, our first speakers, Dr. Anirvan is with us.
Yeah, he's already there.
Okay, sure. Thank you.
The next speaker is Dr.
Can you share the screen? We are back. I hope my colleagues are back. So it's my pleasure to introduce the host of this, the chairperson, for this session Dr. Anshuman Mitra, who is the Secretary and in charge of a National Disaster Response Cell in the Medical Service Center. He's also the esteemed editor of the Health Spectra, and his spare time, I think he worked as a medical superintendent in the Calcutta Heart Clinic and Hospital in Calcutta, India. He is a medical graduate. He has also played a significant role in the Medical Service Center, which is the oldest and largest voluntary organization, and he has a key figure in the disaster response cell. So we could not have a better chair than Dr. Mitra to chair this session. Dr. Mitra, over to you. May I hand over to you to introduce Dr. Anirban?
Yeah, we are starting this session. The session 2 of our webinar, gLocal webinar today, is on man-made disasters. In this session, we had the experience of the Balasore train accident 2024 last year in Orissa, India. And we had the Delhi farmers movement experience, which I will be placing, and the hospital fire at Johannesburg Academic Hospital. Unfortunately, one of our speakers in the next session is being stuck up, so we have slightly rescheduled the session. The second, after Dr. Anirban places Balasore train accident, and Dr. Godakuman and Dr. Amu is the minor landslide disaster in Kerala, India last year. And third speaker in this session will be Dr. Gladys, and the talk on farmers movement, that experience we'll have in the third session. So I introduce now Dr. Ivan to place the experience of working following the catastrophic Balasore train accident. By profession, he's a gastroenterologist, assistant professor in the IMS and Samto Hospital in Bhubaneswar, and on the social platform, Safety of Medical Service Center, Orissa State Committee. So he was leading the entire work we did in the Balasore train accident. What is Dr. Anirban?
Thank you, Dr. Anshuman. I think my voice is audible and slides are visible. First of all, I would like to thank JBI and Medical Service Center for this opportunity to share our experiences in this tragedy, that is the Balasore train accident. The name of the place is Bahanaga Bazaar. It's a quaint little town near Balasore, which is on the eastern coast of India, in the province of Odisha, northern Odisha, adjoining West Bengal, the state of West Bengal. So it was the 2nd of June 2023, around evening, when things were pretty slow since it is a small town. The disaster was that the three trains collided at Bahanaga Bazaar railway station. You can see this is a satellite image that was generated. This is to the north and south. North is towards Kolkata, and south is towards Chennai. So the Coromandel Express train, that is a passenger train that was coming from the north, and from the other side, there was this Bangalore-Howrah Express train that was coming. So this yellow line here shows the Coromandel Express train. So when the Coromandel Express train was coming, on the opposite track, there was a freight train, that is a mail train carrying goods, coal, most probably it was coal. So there was a possible signal failure here, and the passenger loaded train, which was heavily loaded with passengers in its general bogies and sleeper compartments, that veered onto this track and hit the freight train directly. And that train was standing, having massive mass because of loaded coal. And there was a massive collision here. Following this collision, some of the bogies of the Coromandel Express, they derailed. And from the other side, the other train was coming. That's the Howrah-Bangalore Express, Bangalore-Howrah Express. Some of the bogies went aboard and collided with the other passenger train. So it was a triple train accident in a matter of minutes. You can see this is a real-time view. This is the Coromandel Express train. The bogie is lying shattered here. From the other side, this is the Yeshwanthpur Howrah Bangalore Express train. These are freight train here lying. So the images were pretty frightening, to be honest. Nowhere in recent past, in the recent memory in India, such a train accident of this magnitude had occurred. The coaches were totally mangled, and even there was evidence of burn because evidently some of the coaches had caught fire there. So one would not usually be accustomed to such sites. These are not usual train disasters that occur. This was a disaster of the highest magnitude. And then when we, on behalf of Medical Service Center, our team went, we could see the coaches, we could see the bodies and all the things. I am going to give that description. But we found remnants of so many things. When train accidents or when disasters of this magnitude occur, it is not just people who die. There are dreams that are shattered, hopes, ambitions, aspirations crushed. If you could look at the objects, at the things that lie inside this compartment, it tells endless stories of human emotions and ambitions. These are all people's loss. The numbers, I have presented here the official data and the unofficial data. The official data kept changing. It never went above 300, around the range of 270 to 300. But unofficial data, local witness reports, put the number of deaths at 1,000 or even more. There was no way this could be verified or corroborated, but eyewitnesses say this easily tallied over more than 1,000 deaths. Usually in such disasters, it's the disaster response teams which come. But more importantly than that, it is the local people, the surrounding people, the shopkeepers, the passers-by who come to the rescue activities. And it was no different in this case. It was the local people who jumped into the rescue act immediately with whatever instruments and appliances they had, using the common sense. So it was the people, the villagers of the Bahanaga village, the youth, the shopkeepers, the passers-by, and people living adjacent to the railway tracks who are the first responders. This is important because usually we think, we talk about training of the first responders. But who in fact are the first responders? They are the people who actually have no training. So the number of bodies that were coming in was alarmingly high. The number was swelling up with each passing minute. The question arose where to keep the deceased. This was this high school. This is a pretty old high school, completed 70 years of its existence. That was nearby the railway station. That's the Bahanaga High School. Initially, the bodies were shifted there. So the high school became a makeshift morgue here. So the bodies were coming in. This is a small section of the bodies. Many of the bodies had been shifted earlier. This was what we had captured. The Medical Service Center team had captured when they went there immediately the very next day. So you can see the blood stains on the floor. These are all the bodies that had been displaced, that has been dragged away to other places because simply there was no space left. So people are coming, and then the space ran out. And when space ran out, many of these bodies were left on the roadside because simply there were nowhere where they could take these. NDRF, there's a National Disaster Response Fund, and the ODRF, the Odisha Disaster Response Fund, they came in, but it was not immediate. It was slightly late. The people, the common people actually were the fast rescuers and the fast responders. Medical attention did come. Actually, in India, we have this system. We call it the primary health care at the primary level. Then we have the community health centers. And then we have the tertiary centers, district headquarter hospitals. And then above that, we have the medical colleges. So we have the Bahanaga PHC, they are the Soro CSC, Gopalpur CSC, all the people or the injured people, ghastly injuries, they were taken there. Even the bodies were taken there. Some of them were gasping for breath while they were being taken, and they were declared brought dead when they reached the centers. So the health facilities were overcrowded, they were overwhelmed. This was not usual calamity. This was not usual OPD, usual emergency. It was something that overwhelmed every existing healthcare system. The official reports was that over 1,200 people were injured, and that 793 had minor injuries and were released, and 117 and all those were admitted to different hospitals. But the point was that this is an official publication, academic publication by the All India Institute of Medical Sciences, Bhubaneswar, where they had described the different kinds of injuries sustained by the patients, sustained by the people. You can see the spine injuries, fractures, and this and that. But this has been published. But when we visited, to see the wreckage, to feel, and if possible to help. We found the injuries were unimaginable. No medical textbook describes such injuries. This cannot be published. Eviscerated intestines, liver, spleen, kidneys outside the body, aorta and vena cava crushed outside the abdomen. How do you treat these? Contorted bodies, fractures and dislocations not hitherto described. And we found, importantly, no pediatric age bodies or patients at the hospital. Why? Were they simply burned there alive? Were they dead? We don't know. Till today, we don't have appropriate answers to that. I'll just show you a video. I don't think this is a very wholesome sight. Just to show the nature of injury, you can see this. So I have completed my MBBS training of 5.5 years. I have done my MD Masters in Internal Medicine for 3 years, and then I have completed my super specialization for 3 years more. 14 years of medical learning. I do not know how do I treat such patients in this case. Open thoracic cavity, the heart beating inside. So the deceased who had no option, they were deceased. The critically injured were shifted to the ICUs. The lesser injuries, we attended to them in the hospitals. We took stock of the situation and saw whether they were receiving adequate treatment or not. Then we tried to attend to the kith and kin of patients. But we found that psychological first aid, PFA, was the need of the hour. So our team, we initially, so many rescue care workers were there, hundreds were there, and they also needed medical attention. So we tried to give them whatever medical attention, whatever physical attention was required to those people. At AIIMS, All India Institute of Medical Sciences, Bhubaneswar, our team distributed food to distressed kith and kin. They had come to recognize their bodies. The bodies were charred beyond recognition. So bodies were wrapped in packets. We provided help to them. We provided them with food and all these things. But most importantly, our team, accompanied by our clinical psychologist, Dr. Prashanta Roy and Dr. Anshuman Mitra, we visited the site. We visited the makeshift morgue there. We found the people. We found the principal of the school. She was inconsolable. We listened to her, unending string of sorrow and shock. And in the school room, we had a PFA, psychological first aid session with the school principal. We found that she was having severe mental trauma. With the local people, we had the expressions tell everything. So this was the first psychological first aid session we had at Bahanaga High School, the makeshift morgue. We went and met the junior doctors, because at that time in the evening of the district hospital, it was the junior doctors who were rendering their duties, and they were shocked beyond redemption. They were distressed, depressed, and the pangs of pain were clearly visible. We had a session there conducted by Dr. Roy and Dr. Mitra, and these are the people who were actually on that fateful night providing relief, providing medical aid. We found common physical reactions like sleep disturbances, headache, GI symptoms, palpitations, tremors, chest discomfort, aches and pains that could not be described by any particular physical ailment. There are common emotional reactions like irritability, emotional numbness, feeling of panic, anxiety, anger. And then there were cognitive reactions as well. For example, if anyone heard the sound of train approaching, immediately he or she would be having an hyper alert, hyper arousable state. Maybe another train accident is imminent. The constant preoccupation, overthinking, and thoughts and images about the disaster. And there were behavioral reactions as well, like avoidance of the school, talking about the dead bodies in the accident, medical students refusing to go to duty, staying at the hostel, school children refusing to go to school. What we did was we tried to educate them about the normal reactions to abnormal events like this. We wanted to stabilize them emotionally by making them acknowledge their reactions. We emphasized on routine, normal routine work, trying to get back to normalcy. We wanted to tell them about the reconstruction of school association and try to motivate the teachers. In addition, we also tried to educate them regarding psychological first aid, especially the psychologists of the region and the medical students. We could do this because Medical Service Center here in Odisha and other parts of India, we have regular clinical sessions among medical students. So it is the medical students, paramedics, nursing students, health workers, and volunteers who are our strengths. We have regular discussions on bedside clinics, ethics, compassion, and the human touch, because this is what we feel is slowly dwindling, lacking, dying in the art of medicine. So this was the incident in short, but what we felt was that in such man-made disasters and calamities, there are several aspects that need to be addressed. One is the physical, no doubt, the death and the injury. The other is the psychological, the acute stress. After the acute stressful period has passed, the post-traumatic stress disorder. But the more important question is the socio-economic and political question. Why such man-made disasters? Who is responsible for this? Why are the lives of common people at peril? This is just a glimpse of some figures that I wanted to show about Indian Railways, because as physicians, it is our job to know this also. So around 60% of routes operate at about 100% capacity. That is the state of Indian Railways. In 2023-24, 40 train accidents were reported officially. I guess the number is more than 100 if you consider it the unofficial reports. Signaling systems are outdated. Project delays, bureaucratic hurdles, lot of political interference. Number of general sleeper coaches have been reduced. The price of AC coaches have increased. There have been rampant privatization of the coaches. So I'm just coming to the end of my lecture. This is what this great man had said 150 years ago, that the physicians are the natural attorneys of the poor and the social problems should largely be solved by them. Natural calamities and disasters, man-made disasters like these, teach us a lot about the socio-economic conditions that we live in, and as physicians, what our moral responsibility is. Just as I say, I was preparing this lecture on the 12th of June, this horrendous crash happened again in India. It was frightening. The shocks, the aftershocks have not disappeared yet. And MSc Medical Service Center is again rendering its service here. I thank you for your patient hearing, and I again thank JBI and MSc for giving me the opportunity to present this. Thank you.
Hi, it's a pleasure for me to introduce Mrs. Gladys Bogoshi, the CEO of Charlotte Maxeke Johannesburg Hospital, one of the largest teaching hospital in South Africa. Mrs. Bogoshi she's a physiotherapist by training, and then she did a master's in hospital management, and she moved from her practice as a physiotherapist to become a hospital manager. And she is one of the longest serving CEO of the hospital which is the largest teaching hospital in the University of Witwatersrand. She has launched and lectured in many universities and acted as an examiner for both undergrad and postgrad level. The reason she is here to talk about a devastating fire which happened in the Charlotte Maxeke Johannesburg Academic Hospital, and she will share that response. Over to you, Mrs. Bogoshi.
Thank you very much for the opportunity and to share my experience. If my slides can be put in the slideshow, it will help. While waiting for the slideshow, the abbreviation is Charlotte Maxeke Johannesburg Academic Hospital. As it was explained, it's the biggest hospital in South Africa, and it's actually one of those where we are dedicated, the only dedicated hospital to deal with highly infectious disease. And the importance of that is that the fire happened in the middle of the COVID-19, where we were the first respondents. If you can go to the next slide, it's still not yet on slideshow. And if you can move to the slide where there is the hospital picture, that's correct. It's now on slideshow, yeah. So you can skip the next slide. Those are the topics I'm going to address. Charlotte Maxeke, as you see, it's a huge hospital, and the whole white building is the clinical area. You can see it's got 5 blocks, but it's got 16 floors, of which 9 are functional, 6 are interfloors, and it's got a high rise on my left-hand side, and the ones on the right-hand side is the low high buildings of the hospital that are north-facing or south-facing. The big building on my right-hand side is the medical school of University of Witwatersrand. Go to the next one. So this hospital is one of the 10 central hospitals, as I've said, and it served the population in Gauteng of about 5.15 million. But we also are responsible for the SADC countries around, including the other provinces called Limpopo, Northwest, and Mpumalanga. So go to the next slide. I will skip a few just to show you. So we have what we call a referral system and a cluster system. So as you can see, we are in the center. and you can see the provinces and the districts that I have mentioned. Of importance is that these districts have got all levels of care, with one having a central hospital, which is the Johannesburg area. And the Johannesburg area is the most densely populated, smallest town in South Africa. Go to the next one. It shows you the population only in Gauteng, not the other provinces or the SADC provinces. Go to the next slide. Now, the hospital gives all the service packages, as you can see, and the next slide also shows the other services that we run. In essence, the only thing we do not do at Charlotte is the heart and lung transplant. So you can imagine the importance of this is that we had all these type of patients because we are highly specialized. We are the most developed, where we do about 85 to 95% of highly specialized services, where sometimes we, for example, the liver transplant in South Africa, we are the only ones who do it for the whole country, whether you are in another province. Jump the next slide. Yeah, so these are other services that we do. Go to the next. So the fire incident happened on the 16th of April. Go to the next slide, yeah, at about 11:20. And so when it started in the special dispensary, which is in the parking area. And the way the hospital is designed, as you see, is one long building. So we continued operating. And at that time, there were over about 854 patients who were in the hospital. We made a decision to move the patients, not because of the fire, but the fire was well contained where it was due to the way the structure was. But the whole hospital was full of smoke and soot. And so everybody was choking. So we did it in phases. You recall the building has got the north and the south side. So the fire was on the north side. And then we had to move the patients to the right side. And in the evening on that day, around 21 hours, we decided that we are going to move the patients out of the hospital. So go to the next slide. It will show you where, yeah. So yes, so if you look at this thing, you will see that same building, it's got different blocks, where the red part is where the fire happened. Of importance is the oncology unit that is outside there, and the admin building, which is not part of the hospital, as you can see. And all those 850 patients were around that whole area that is written block 1, block 5, including oncology unit. And of importance, this hospital receives about 1,500 outpatients over and above the 854 patients on a daily basis who are coming for outpatients. And we also have 33 theaters who are operating. So when the fire started, all those were in action. And so the first people who were removed was the outpatients, in terms of ensuring that they are safe, because most of those outpatients are on the northern side next to the red part of the building. Continue. The next slides will show you how bad. This is the fire at night, where there was a wind that actually reactivated the fire, and it was just chaos from there. Go to the next slide. It will show you, as you can see, this is how bad the fire was. A few slides also show the next one. Of course, this is the damage that was happening. And above that, there were patients that we needed to move first. The hospital. Go to the next slide. And this was the aftermath of it. And if you look on your my right-hand side, the red area is the areas and all the wards above that were affected by this fire. Go to the next one. So in terms of that, we actually had to move these patients to 17 different hospitals at night, and it took us 24 hours to move them. A few of them were sent home because they were almost about to be discharged, but everybody was removed from the hospital. And we started with the adults, and there was a reason for that, because the main issue was that we needed to have the ones who were closer to the fire, and the children were further away from the fire incident. So the most important thing that everybody I really would like to know is that we had a disaster management committee. Our advantage was that the disaster committee was already working because of the COVID-19. So now they had to make that call and actually do this, prepare the personnel, and also ensure that everybody is moved wherever they were. There were many debriefing of the staff members. And fortunately, because we were the only COVID-19 hospital when we started, we had a lot of our own staff from psychology, occupational therapy, psychiatrists, and what have you, who had formed the team over and above the wellness committee that we have in the hospital. So people were just busy minding their own business, and they were told, get into this car, you are going to Steve Biko, which is 60 kilometers away. But those who came in the morning, they were also told when they arrived, because they didn't see this thing at night, they were also told, get into the car, you go into whatever. And that was going to be their lives for the next, I think, about 6 months. So the debriefing happened on a daily basis. But us as management, because now we have patients all over the place, remember they left with what they had. We had to actually make sure that we visit them wherever they are. So on a daily basis, all of us, including our labor relations committee members and the senior people, we went to visit and really tried to support them. The next thing is that we had meetings with the governments from the province and the DG to help us reduce some of the challenges that we had. Very, very important when you have a disaster to have the structures put in place. Go to the next one. So we had different stakeholders, the internal and external. Circulars were coming out, social media, we used everything. Many super visits by EXCO to everybody, virtual meetings every day. We also had to respond to what we call Chapter 9 institutions, like the Office of Health Standard and Compliance. Many of the people who wanted to know what happened, emails were used. And we were very fortunate because the hospital was already well developed into our virtual meetings. We could easily put about more than 400 patients, but we also connected in our auditorium that can take 1,500 people so that everybody can know what's going on, because everybody was panicking. Go to the next slide. So now we had to come back because we were going for the third wave. And this is what is important. Remember, the patients were still, just to remind you where the fire was. We used the clinicians to help us to say, well, how do we do? Because the engineers came in and confirmed that the hospital is stable. All what we need to do is to ensure that we have the whole Office of OHS compliance and the City of Johannesburg, which is legislated to ensure that they allow us to come in. They agreed that they will give us what they call a certificate of that I can occupy the whole area that is white and not the area that is red, to make sure that at least we can take those 850, because all the hospital could not manage, and we had to actually bring our prepare for the fourth wave, which started around November the same year. Go to the next slide. So this to continue, yes, I've just explained that. Go to the next slide so that I can, So the plan, what is very important when you have this disaster, the clinicians through the disaster committee must lead, but all of us, including the infrastructure and everybody and whatever, we need to go with them. So this was the plan that was put in place to make sure that we bring those that we knew nobody in the province could do them. For example, the liver transplant and like radiation oncology, we were the only 2 hospitals that were doing, and our unit is probably the biggest in the whole of Africa. So we had to make sure that these patients come back. Go to the next slide. So these are the plans. So yeah, that we did, as you can see. So phase 1, all phases were, the green one, as you can see, we had phase 1A, phase 1B, and all of those being present. Go to the next slide. So as you can see, currently, this is where we are. The hospital is still being repaired. It's still going to continue next year. And all of us here, I must say that if you put the systems, the governance is in place. We have made sure that everybody is back in the hospital. As you can see, we are back to 1,068 beds. We have used every bed. We run at a bed occupancy rate of 83%, while about 30% of the hospital is still not available. We had to open our accident and emergency, as I said, and that was the first place where we managed to get, including our theaters, because our theaters are highly specialized in terms of what. But we had to also return the patients who were COVID-19. And currently, as I'm talking, I mean, some of the clinics are running in the residences. People had to make plans. Sometimes I have to get out of my office and sit in my car so that somebody can do whatever they want to use my office in. So what I'm trying to say here is that when you have a disaster like this with a hospital of this size, the priority should be clinical space. All of us, it's luck if you have a room. Whether you sit under the tree or you walk and you sit outside, as long as you can perform your duties. Go to the next slide. So the staff wellness, I have spoken about it. As I said, we have operated it. It operated during the day. But what we tried to do, we brought the other, people from other things that we assisted in terms of the NGOs from outside to offer the 24-hour wellness session. Go to the next slide. So we had to develop a risk matrix. I won't go into it. And the reason we developed this, because remember, we had to make sure that we bring these patients back before the third wave. So we did this with people who are really trained in this risk matrix to decide the impact and the likelihood that has doing. And as you can see, there was clinical risk, there was staff risk, there was safety risks, and we also actually had to rate them. The next few slides, if you can just move, I want to show people how we did it, so that when we decided that we are coming in, we needed to do this thing. When we did neonatal, for example, the top 5 clinical risks, these are the ones that we identified, and we had to say, how are we going to mitigate them when they come back to the hospital? So just go until you finish all this. It was just to show you how detailed the risk identification and the fire safety was done. Continue. I think that's, yeah. So it was a balancing end. Do you bring them? Patient safety risk impact is disastrous, but likelihood is lower and has been managed through safety versus clinical risk and high risk. Likelihood of impacts were also, so we were doing this on a daily basis. Continue. So the lessons learned. I want to talk about the role and responsibility of the disaster committee. You need to have an active disaster committee all the time, so that when they have a disaster, within 10 minutes, they must be activated. Here we have a system, an SMS message, where we even use it for the drill. So the fire happened at 11:20. By 11:25, I was not in the hospital, I got a message, red alert. Everybody in the hospital got it. Everybody knows where to go. But we also had to activate the command center immediately. We activated it under the tree next to the fire, I think somewhere where you saw that. But when we saw that the fire was not getting better, we then moved to the boardroom where we put the disaster committee. The disaster committee led through the Clean Marketel team, and I put a number of support people like infrastructure to help remove the obstacles. The head office also needed to help. And like the previous speaker said, sometimes they really disappointed us. And therefore, in terms of that, we had to actually manage as the people in the hospital. Go to the next one. So the other thing is that the patients and families, communication, as the previous speaker said. Remember, we moved their people. Some of them were from maybe Zimbabwe or whatever. Everybody, when they saw the fire, we did. I must say that the Premier's office had a 24/7 hotline, and we put our people there where we were operated to remove their fears and what have you. And the beauty of the whole thing is that we did not lose any patient. We could account for every patient. And to date, we can tell you who is where and where. Where we had challenges was the families where we could not get them, but eventually they contacted us. There's the daily, every day for 3 times a day, we had to have daily briefings and hear the staff. The most important thing was that the meeting was not only about me as the CEO or management telling staff what to do. We had to listen to them. We gave them where we are and we listened to what we are saying. And therefore, if we needed to go and dispatch a psychological team, that's where we made this. As you can see, we had daily 3 times a briefing, 2 being with management, the first one at 7 o'clock and the mid one during 12. But at 3 o'clock, we had everybody online. Whether you were in a hospital that was wherever or you were home, you could join. The external people also, we wanted to tell our story. We didn't want the media to actually say what's happening. So if there was a disaster in a disaster, we would make sure that we communicate it first before the media comes, because it's very stressful now to try and respond reactive when you could have been proactive. So on a daily morning, every day at 6:30, before we have the 7, we needed to decide whether we're going to have 1, 2, or 5 communication meetings, or we're going to send a bulk SMS, and to who. If it was needed to the doctors, we had all those put together. I think it's the last slide. Go to the, yeah. So regular management, yeah. Don't go to the previous one. Regular management and heads of department visiting. This is very, very important. When they saw us, you don't know how much. Some of them cried, you had to do this. Visibility. Create a direct line to those in distress. I don't know how many times I got calls at 1 o'clock where some of them, you know, where they went, they were not well looked after. Wellness committee worked, and as I say, the support committee was there. Resolve issues with immediate effect. Those who, as I say, they were not welcoming, we really tried to make them comfortable, tried to also make sure that they get from you know, the resources that they did not have. And also the biggest problem is that we had attrition rate, because a lot of people left, and where we could fill posts in the middle of the whole mess, in between, HR had to make sure that they either get agency or whoever to minimize the pressure that the people had. And in conclusion, the last slide. You know, we are on a program called the Lean Management and Coaching using the what do you call this thing? I'll just remember the name now. And one of the things that I learned, we started this in 2017, that you need to develop your frontline staff to solve their own problem. So because of the model cells that we have started, what we used to do was that we used to do a lot of walkabouts. We call them Gemba walks, so that we go there to see the good work, and we gave staff a confidence that they know what is happening. All what they need is their support. So your walk to the Gemba was to go and see the good work and to remove the obstacles that they had. We also tried to listen to understand what they were saying and not respond to what they were saying. And because of this, our staff were able to make a plan. They sorted out problems. Most of the time they said, CEO, this is what I've done. I've put this patient in the passage. I've done this and this and this. And because they had confidence that they knew that management is going to support them. Decisive decisioning is very important. Sometimes with your gut feeling. One of the things that happened when the smoke and smooth was there, we ended up with smoke there and there were windows. And I remember Prof. Mutara calling me and say, we break the windows. I thought it was one window. When after the fire, it was so many windows that were broken, but the aim was to save a life. Thank you very much.
Thank you for a wonderful presentation. Let me hand over to Dr. Mitra to introduce the next speaker, Dr. Prof. Ammu. And I understand Prof. Ammu will share the screen.
Yeah, Dr. Godakumar and Dr. Ammu are there. They'll be speaking on the Wayanad landslide disaster. Dr. Godakumar is a people's physician, and Ammu is a clinical psychologist. I request Dr. Gorakamo to come on the screen, unmute yourself, open your video, and share your screen. Dr. Gorakamo, please.
Hope I am audible.
Yeah, you're audible and visible. Slide is visible.
Good day to all the delegates. And first of all, I express my gratitude to giving me this opportunity to present our experience during the Wayanad landslides in Kerala, South India. Myself and Dr. Amu Lucas will be presenting in this 15 minutes, so I will restrict my time to bare minimum. Wayanad is a serene mountainous district in Kerala. It's in northeastern part, in the western Ghats. It is there. Most of the activity there is tea garden estates, around 5,000 hectares of tea garden, and most of the people depend upon this tea attending tea garden jobs. Kerala gets almost 6 months continuous rain in a year, and the recent global warming and climate change has worsened the situation. On the one side, extreme heat in the summer and downpour in the rainy season. This makes the land very soft, very much soft, and particularly the mountainous area, this tropical rainforest area of Wayanad get soaked and drenched, and it occasionally slips. This mud slips are there. But in last year, 2024, July 30th night, it was a massive avalanche of landslide, because this water-soaked mountain and the soil slips from the rock underneath, and it snowballs like anything, and around 7 kilometers of soil was eroded, and around 500 hectares of land was lost. The slide shows the previous picture and the picture after the disaster. These are the pictures the time of disaster. The two villages, Mundakai and Churalmala, was completely shattered and houses damaged. This is when we visited there, 10 days after the disaster. The graveyard like deserted land it became. Big rocks they came like projectiles through sky and shattered buildings, tons of kilos weight. Then this is a very sad photo of the mass graveyard of anonymous bodies. Many residing there were migrant laborers from North India, and they had not even their documents. So according to government, around 500 casualties were there, but local people were telling that it was almost 1,000 people dead who had no Aadhaar cards, their documents, their identities, their kith and kin lost, their all inhabitable place. 2 villages were completely eroded or erased from the map. There was immediate response as everywhere by the public, NGOs and common people, and government also came in for rescue and relief activities. Medical Service Center was prompt in its response. On the next day itself, we started and reached the spot, because this area is strategically very difficult area, because we have to drive 80 kilometers from the nearest city of Calicut, Kozhikode, and the nearest railway station. So accessibility is very difficult. We have to pass through mountainous pass, Wayanad pass we had to go through, so it is very difficult. But within 2 days, we could make a base medical camp, establishing a medical camp at Mepadi, adjacent to the disaster hit area, with the help of the local community. Local people were engaged in all the activities, in discussions, planning, execution. There was very much good cooperation by the common people. Our medical team. And a call was given to donate medicines, and medicines and other equipments became available for the activities. There were the problems that people faced were multitude, because many of them were in the relief camps, affected people, and the other people they had to remain in the vicinity. They were left without any support, because all the public health care were diverted and channelized to the affected people in the relief camps. So general population had no way to approach the general government hospitals, and private hospitals were few, and there are big corporate hospitals, some medical colleges, but it was not affordable to the common people. And we had to have some outreach camps by walking some kilometers. We had to reach their villages, remote villages. Then the residents of tea estate workers. These are outreach camps. 10 outreach camps we organized. The tribal villages, common people are living in remote forest areas. This I told that dense forest is there. With house visit by our doctors. And a special focus was given for psychological first aid and psychiatric treatment. This is a team headed by Dr. Abraham, a senior psychiatrist who had 40 years of psychiatric service in Canada, and Dr. Amu Lucas, an experienced clinical psychologist. They combined together to give psychological first aid and psychiatric treatment. Yes, these are voluntary groups there from the same locality community. They're called Abad Mitra, Friends in Disaster. They're community rescue and relief team. We gave counseling to them, advice to them, guidance to them, and also we interacted with the security personnel in that area. And the challenges we faced, I told, this dense forest area where people are afraid of coming out of their houses just after 6 p.m. In the evening. One sun sets, tigers, elephants, and wild boars roamed around even small towns, and people were afraid. And there were man-animal encounter in many places. Heavy rain and thick mist, bad roads, all these are our hurdles. But we could continue our camp for 40 days, continuously giving assistance to the public. And in this activity, around 80 volunteers, 40 medical volunteers and 40 general volunteers, out of which 19 doctors and other medical students, clinical psychologists, counseling psychologists, nurses, pharmacists, masters in social work, all were included. And for these 40 days, we could attend around 5,000 patients. And after winding up the camp, there was a get-together with the public, and there was experience sharing session, and there was emotional experience shared by the common people, and it was a moving experience for all of us. But even after finishing this psychological, this 40 days camp, Dr. Abraham and the psychology team continued their counseling work for and psychiatric treatment for two more months. That is, up to November, we continued it, and there was two medical camp twice a week were organized, and even after that, we went beyond the call. During the Christmas holidays for children, a medical children's camp was organized. 2-day children's camp from the affected areas and also the vicinity. Around 200 children participated with their songs, their recreation activities, drawing, then storytelling, dances, paper craft. That is a very happy ending of our program. There are education programs for training in first aid, then dental hygiene. One class was there on the life struggle of Madame Curie. One good film was shown, The Children of Heaven from Iran, this Majidi's film. So it all ended in a happy note. That was the final phase of activity. Almost 6 months we were with them, and still there are a lot to be done, and those things are to be done by the government, rehabilitation activities, building new houses. So that's the thing that I have to place, and I will request Dr. Ammu to place about the psychological interventions. Thank you.
Thank you, Dr. Kumar. I request Dr. Ammu to kindly unmute yourself, your video, and share the slide. You stop sharing, and Dr. Ammu will start the sharing. Dr. Ammu, please take the.
Am I audible? Am I audible?
Yeah, you're audible. Yeah,
okay. And hope I am visible as well.
Yeah.
My slides are visible.
Yeah.
Okay. So thank you, Dr. Kumar, and thank you for this opportunity by GBI. I will be representing Medical Service Center, the Kerala State Committee, and the psychosocial team, which acted during the Wayanad disaster of 2024, presenting on experiences and challenges. I would like to call this as a psychosocial intervention than calling it just as a psychological first aid, because we had a very good integrated multi-disciplinary aspect. So that is one of the take-home message we had from this experience. So my presentation representing the will be covering the process, observations, and challenges which we had during this process. To start with the process, in terms of preparation, when Dr. Kumar mentioned, when the MSc team volunteers went for the base camp and set up the base camp, the medical services, it was identified by the volunteers itself the amount of psychological distress people were undergoing. So MSc volunteers themselves suggested a psychological first aid or a psychological intervention from the MSc team. And in Kerala, for the MSc, the fortunate part is that we have 2 clinical psychologists on board, Manav and myself. trained clinical psychologists, RCA recognized clinical psychologists. So what we did is to do a psychological first aid, WHO psychological first aid session for the base camp volunteers itself. The purpose of that was to generate insight on normal psychological reaction, like Dr. Anirban was mentioning, the normal psychological reactions after, and how to start befriending. I will come to why it is very, very important. Psychological services, how we started was Manav Jyoti, in the photo you can see him. He's a leading clinical psychologist and he came to MSc State, he's also a member of MSc State Committee. He integrated the initiation of integration of psychological services in the base camp. He started off with one-to-one session in the first week itself. From that experience, we also understood that manpower is required. So we started networking with the psychology and social work fraternity in Kerala. But by third week, I reached there and tried to extend the psychological services to community by house visit and phone calls. And during that time, we also expanded our services to the fire and rescue services and KSDMA, which is called as Abat Mitra. 3 modes of service utilization is what we could see. One is self-initiated by the people itself, by the community, saying that there are people who need psychological help. So it is community initiated, and we could not identify many people who might have required psychological aid. One good part is because we started off psychological services, the neighboring community who had underlying psychological issues also started utilizing the services. During this work, what happened is that, like Dr. Bodhakumar was mentioning, Dr. Abraham, who is not part of MSc, a psychiatrist retired from Kerala, Canada, but a very good humanitarian, walked into our base camp offering his services. And then it became a breakthrough in our service delivery also. Under his leadership, we could actually give an exemplary interdisciplinary mental health care which got emerged and translated into practice. Why I mention it is many a times because of the ego, which is predominantly seen across the world, and in Kerala we see a lot of ego between the psychiatry, psychology, social work team, which was not at all there, and we all work together for the same purpose of helping the people on the disaster affected people, which became extensive community and house visits by the team. Active listening with, this is photos of what we did of active listening with friends in disaster, which is Abat Mitra, the community rescue team and security personnel also. Civil defense workers visited our base camp. Home visits were extensively done to identify people who had psychological distress. We try to reach out to the distressed people in the affected area itself. Like Godakumar was mentioning, the affected places, people were still hanging out. The government had mentioned that not to be in that place because it is prone for next disaster also, but people were still hanging out. People were using substances. Their use of substance had increased after the disaster. So this is a brainstorming on future plans with the community involvement. Dr. Abraham very much involved with the community. Home visits, and so we utilize the children to reach out to other people also. There was a secretary, Kerala State Disaster Management Authority, KSDMA, Dr. Shekhar, and we tried to communicate to him our 2 major concerns from the psychosocial team, which is one about the disbursement of people. What government had done is that after the school camps were over, the relief work was over, all the people from Mundakai and Churamilla was dispersed to other parts of Wayanad, which was very, very distressing for the people, because this community is a community and psychological distress could have been reduced much level. The multitude could have been reduced, but it became more because of the disbursement of the people. So we mentioned that to him. And second thing is that we also identified that this Abat Mitra team were taking up responsibility of many of the death which happened in this place. So we also mentioned that they need psychological kind of training during their other training, rescue trainings also. Like Godakumar mentioned, the Hope 2025, the children's camp actually emerged as an idea in the psychosocial volunteers. The main purpose of Hope was to reinitiate the cohesiveness in the community, and many children and the people could meet their fellow members in the camp, which was a mind-blowing thing for even to us as well. A free psychiatric clinic in Mepadi was set up by Dr. Abraham. Observations we had already, Dr. Godakumar mentioned the impact of death, how many death happened, missing, displacement and all, to the level that 35 family members were missing for a family. Maybe one person is just alive. There was a 5-year-old child who is the only person alive. All father, mother, siblings were lost. So this is the extent of impact which had. Displacement was there, loss of home and property was there, loss of livelihood, homestay, hostel, loss of job, etc. were there. Like WHO and other research publication mentioned, any disaster is like a domino effect. It is not the primary impact, also has secondary and tertiary impact. A family member who is the earning member, losing that person is not the physical loss of the person. It also has psychological impact, then has financial impact and social impact. A common reaction to stressors, majority of some kind of psychological change, like already established research, but no, everyone don't go into trauma. And these reactions were expected, and psychological stress improve over time. There is a time factor. Majority had distress, only a small number was chronically traumatized. Reaction was dependent on different risk and protective factors. Similar to what Dr. Anirban had mentioned, the common physical reactions we could also see in terms of the biological rhythms, headaches, decreased appetite, and various other physical reactions. Emotional reactions, tension, irritations, feeling hopelessness. How we arrived at this data is from the notes Dr. Abraham had written or we had written, or any of the counseling sessions which we had. So from that, we could arrive at all these reactions. Cognitive reactions were also found. Common behavioral reactions were also found. Clinical observation is that only a few survivors experience abnormal reactions, being withdrawn, disoriented, having low-term mood disturbance, long-term mood disturbances. Increased substance use was one of the major issues, causing harm to self and others, poor self-care, difficulty to work. One of the major protective factor is the social cohesiveness and befriending. Community cohesiveness and befriending is something which acted as a protective factor. What aggravated the reaction is main support system was lost, loss of children, death of many family members, community displacement, uncertainty in livelihood. What are they? Like Godakumar was mentioning, it is more plantation work which they were doing, and the plantations are not there, or the hostel is not there. What do they do now? So livelihood, past history of mental health issues, ongoing family conflicts, suicide attempts if it is there in the past, addiction in the past, and past history of impulsivity. Focus of our work was what is the normal reaction to an abnormal event. We educated people. Emotional stabilization by acknowledging reactions, ventilation, but no forced ventilations, discussion on possibility of normalizing the routine, linking to the family and friend support system, like the children's camp, allowing ventilation if initiated by the individual itself. We didn't, like I said, we didn't force them. Creating hope. Hope building was one thing which we focused on. Identifying warning signs and refer to DMHP. DMHP is the District Mental Health Program. Medications if necessary, which was handled by Dr. Abraham. Protective factors, community support system, and if the person had their own resilience of hopefulness, it acted as a protective factor. Challenges which we faced is predominantly from government had all these school camps had lot of psychologists, counselors. It was like a humongous number of people who came to the camps. after the disaster. And what happened was that predominantly there was a psychological debriefing overemphasis in most of these government-led psychological services. And in fact, many people even mentioned that if you come and tell us that you are a counselor, we are going to beat you. We don't want to hear anyone saying us counselors. So that is the level of fed up by the people over there. So it actually stigmatized the concept of counseling itself. What we tried extraordinary was to let people know that we are here in the base camp, and if required, please approach us. There is no intrusion. And and the other challenge we faced was that even if there is a major risk factor like self-harm behavior, which cannot be handled by Dr. Abraham, government system referring to that was a major challenge. We also tried to reach out to a NGO working in Wayanad. And as the people were already dispersed, the affected people were dispersed across Wayanad, accessing them was one of the major challenge, because government was not ready to share their list at all. They were thinking that all other people other than government has come with some other manipulative kind of a idea. Lack of manpower and financial resources, we faced a major challenge in that. Community gatekeepers identification and training is one area which we really wish to focus on. To some level, we could do that using the Abat Mitra team. Standardized documentation of the clinical record with a focus on scientific publication, because we feel that our work is very, very scientific and very, very humanitarian oriented, like MSC's motto and focus was mentioned by Dr. Tarun Mandal. So it needs to be scientifically published. However, this was our first kind of an experience. So we couldn't document it in a standardized way, which is going to be our plan. Suggestion is, along with the survivor, frontline workers needs to be monitored for psychological needs, which I mentioned. These are the two pictures which came out because of our work by the children whom we actually. So one of the painting is by my own son, who is in 4th standard. He was all along with me in this work, and whatever he reflected upon is one of the paintings. So this is one level of extensive not only the people in that area, we could reach out to other people and tell the need of the psychologically sensitive kind of work required. Thank you very much for giving me this opportunity by GPI. Thank you.
Thank you, Dr. Amu. We got a detailed discussion on how from a all-out crisis, a medical team could develop the psychosocial intervention approach, integrating psychological first aid, psychiatric and psychological backup work, and linking up with the government and other systems, hospital system, which did not have the outreach. So the people, victims, the general population at large also face acute trauma, not only the affected families, but everyone around, including, as you saw, Apta Mitra, the firefighters, all the people, they were affected all around over more than 30, 40 kilometers. Generally, we fail to understand. And we could intervene. This bridging we could do, and we could intervene in a very beautiful way. So this is a model upon which we develop. So this session is an end. In the chat box of Basu, you can see the name by DB initials has given an email. Actually, we had a question answer session. Already the session is truncated because this is part of the natural disaster item of session 3, which is here some management issues, and the issue of the man-made issue of farmers movement is the third session. So we'll have Q&A totally at the end, but all who are interested, I think Many of you who commented in your registration form regarding the awareness of mental health and disaster and the challenges which is not readily handled. So we actually from Medical Service Center, my sound is okay. The sound is better now. From Medical Service Center, we are working towards a full initial course and a developed course in psychological first aid. So all questions, all points which are relevant, please put in the chat box and also in the mail, both in the chat box and in the mail. The mail I'll again repeat, jbi-ekurhuleni @outlook.com. This is the mail given in the chat box. Please all copy and also put your questions and pointers. Any points which should be covered, any issue we should be doing in natural disasters, please put forward. And at the end of the Q&A, we will try to cover up all the issues as much we can do. But the session, the question answer, the answers have to continue later. That is why we need all your inputs, comments, and mails. So with this, I hand over the session to Professor Dev Basu to move into the third session. I think tea break also we can forego. Just we can break for 2 minutes to again for the next chairpersons to get in line, and the speakers, as I understand, Mukesh Senwal is already on the line, and then I think Ms. Saptarshi can place, and then at the end, since my talk is about the man-made issue, I'll place at the end. Over to Basu.
Good day. Can we please take a comfort break for 10 minutes? I know that we are running a bit of time, but let's give us a comfort break for 10 minutes and then we can reconvene.
Okay. All be on the line. All the questions who are have points of questions, please.
So we in South African time will be back at 12 and Indian time 3:30. Is that okay with everyone, Dr. Mitra? You are muted.
Yeah, that should be fine.
Yeah, okay, yeah.
So let's get for we'll reconvene at 12 o'clock South African time and 15:30 Indian time. Thank you. And in the meantime, please follow us in the Facebook. We have around 130 people already joined the Facebook Live. And please, when you go to the link, please follow us to the Public Health Medicine Department so that you can get access to it. And all the details are in the chat. Thank you. Hi, good day, everyone. Welcome back to our last session of the day. It's a pleasure to welcome our speakers, and please follow us in the Facebook. We are actually now moving to the last session, and it's a pleasure for me to introduce the two facilitators. The first one being Dr. Prashanta Rai, who is the assistant professor in the Department of Clinical Psychology at University of Calcutta, India. And he is also an assistant professor in the same university. He has an enormous 20 years of experiences. He published 37 papers, and he presented in both international and national conferences. He received extensive training in the psychology, and his interest includes cognitive and behavioral therapy, hypotherapy, and psychometric medicine. So, and my second facilitator is Dr. Anand Van, also from India, who is a medical doctor and bioethicist over 18 years of experience. He also graduated from University of Toronto and PGDMLE in medical law and ethics from the National Law School in India. He currently serves as a mentor, a principal investigator, and project lead in the Bhopal hub of Sangar in India. He is the immediate past president of the International Association of Bioethics and currently serves as an adjunct professor. He is also published widely and presented in a number of conferences. So over to you, the two co-facilitators. Dr. Prashant Rai, can you hear me?
Yes, thank you. Am I audible?
Yes, please go ahead.
Thank you for JBI for this nice initiative where various speakers and the activists, I'll call them activists because though they are professional, they are working in the field since long. So they are presenting their experiences in various man-made and natural disasters with particular focus on psychosocial aspect that was being ignored, particularly in India till 2004. After tsunami, there was much concern about the psychosocial aspect, but still there are lots of gaps. People think about PTSD only whenever you talk about psychosocial aspect of disaster. And in this session, we'll listen from Dr. Mukesh Semwal. Dr. Mukesh Semwal is a political scientist who has done his PhD in political science from Baroda University. Now he is staying in Uttarakhand, and because of him, the medical service center could materialize a significant work in Uttarakhand 2013 flash flood. So before we hear from Dr. Mukesh Semwal, Dr. Anand Bhan, would you like to say something?
Thank you. Thank you to CPHR and GBI also for this opportunity to be part of this discussion. Here is a really crucial area, as we know, with also factors such as climate change and a lot of stressors that we are seeing, including conflict and changing sort of geopolitical issues. We are likely going to be seeing more and more of disasters, both natural and man-made. And as was alluded to, we have also already in the last few decades seen devastation due to a variety of factors. And so this issue of response, especially psychological response, and how to embed that within disaster response is an important topic for discussion. And so it's really nice that today we are all convened here and we have such a large turnout which is looking at this issue. So since we're already running late, I think we can just go into the presentation, and then please feel free to also share your comments and share your questions in the chat window so that we can direct them to the speakers once they have finished their presentations. Dr. Mukesh, if you could start your presentation, over to you.
Thank you, sir. My presentation is about. Am I audible, Prasant?
Yes, you continue.
This is a temple that we are seeing in the screen. It's a Kedarnath temple. There was a massive flash flood in 15th and 16th of June. This temple is situated at 11,000 feet height above sea level. Just behind that a small rocks and all that seeing. First, this occurred in 15th and 16th of June. A survey team, I along with 3 of our university teachers, we went from Srinagar to Rudraprayag, and from Rudraprayag by walking, because all roads were washed out, to Chandrapuri, where we sought out how to check it out. Next slide, please. Next slide. From 30th, our pilot project, a pilot team came, and it advanced to 6th. We spread our advanced camp to a place called Banswada near Bhiri. That is on the very route of this Kedarnath route. There we established a laboratory also with the help of Lady Hardinge Medical College, Delhi, established a very update kind of laboratory, which blood sampling and all that we conducted. That was in that whole area. It was an only laboratory which we established. Again, next slide. Next slide. This is in an area, district of Rudraprayag. Then this advanced, from Rudraprayag base camp as well as advanced camp, we spread in every directions of these villages. Our medical operation, with the help of very dedicated medical service doctors, medical staff, they went to, with all medicines and all that, climbing up in the villages. All roads were washed out, bridges also were washed out. This was only because of local population. We can organize these medical camps from our advanced base camp as well as from Rudraprayag center camp. We organized in various villages. Many of the doctors which are present today, Dr. Anshuman Mitra, Dr. Vigyan Behra, Dr. Prasant Roy, they also were a part of this whole operation. Next slide. As I mentioned, that this calamity was one of the very worst in that area, as because of hilly and mountainous region, all roads was washed out. So even the chronic patients also of suppose hypertension or diabetic, for them also we charted our medical services. From June onwards to August, we conducted everyday medical camp, and then for a week up till June 2014. And in all the area, one of the most diseases we found it waterborne GI infections as water contamination, jaundice, and respiratory infections and skin infection. Because of actually this calamity was a waterborne calamity. This also led to this. Next slides. Yeah. This is one of the, in that area has potable drinking water and all that, because water pipelines and all that were, it was disturbed because of this calamity. So we conducted as a cleanness and all that, chlorine tablet, bleaching powder. We also launched filter making and water purification with the help of a science society, very committed people science movement. That's a breakthrough science society. In schools and all that, we conducted making of filters and how to use the drinking water, as availability of drinking water from the upper sources were all disturbed. Next slide. Next slide. Or I should share it, Prasad bhai. This is for a year round. Psychological trauma has conducted, as it was a direct reaction of this calamity, that families and mostly missing members, as the total number of calamity, this casualty in that is 6,000 people. Even still after 12 years of calamity, there are still 275 bodies that DNA testing also, that still they are missing. And ultimately after 7 years, 4,600 bodies, they were missing bodies. So this all leading to, or in that area, this was a June area, that was a June area has a very rush towards this temple site of Kedarnath. So many local people, they were missing in that calamity, which has led to a very kind of very psychological traumatic for whole families. One village in Kedarnath, near Kedarnath, there are 38 widows in that very village of Lamgondi in upper area of Uttarkasi. Next slides. Next slides. or I should share it. This is a way. The first slide is of the upper story of a house. This is I say about this, what common psychological reactions it is as a part of any calamity: fear, anxiety, sadness, emotional numbness, anger. This was visualized when we, in our camps also, this medical activity, they came, nightmares and flashbacks and arousal, disturbed sleep. Is all part of when our medical activity was going on at medical. This was a kind of reactions that we received from our patients as well as their families also. Next slide. We conducted a psychological among students also. Next slide. This is what we did immediately, asking about the common psychological reactions in our medical camps. This was very much helpful as and after this psychological treatment, we actually targeted to children's in 3 secondary schools that was completely devastated. We conducted a psychological trauma assessment. 123 school children were selected. Out of this, 66 were having a traumatic symptoms. This was a team led by our psychologist, Dr. Prashant Roy, to a school called Tilak Nagar. Tilak Nagar is in a Tilbada area where their students were saying that school was being systematically kind of, it was not ravaged during June flood, but as because of river below, it was carrying the silt, and which has led to a downfall of the school. Very slow that the school was, even children were seeing with their eyes that every day our school is sinking. This was land sinkage. Next slide. A group of as a psychological first aid games and role were taken up, and as a part of this psychological first aid, we every school has a national social service volunteers, which is called an NSS. They all volunteers as well as school teachers. It was identifying the reactions of children, and we managed to work it out. And this exercise was very much fruitful. And this district is our where this Kedarnath calamity occurred, that was Rudraprayag district. This was first of such activity in that district, this Rudraprayag district. This was appreciated by our even government officials of health department also about our this psychological first aid. Next slides. Or yeah. This is the last slide. Actually. This is the last. This is actually after this all calamity and all that life goes on in hills. This is in Rudraprayag. We organize as a part of Medical Service Center. We organize candle march and various kinds of program. This is also a part of psychological a kind of treatment also to normalize the life within it. Actually, this data is we conducted around 232 camps and in 300 villages, this whole area. And from June 2013 to June 2014, we conducted this activity, and this was a very much needed of the hour. And still, many of our suggestions that we provided it were taken up by state government and health department. That's all. Thank you.
Thank you, Dr. Mukesh, for presenting the medical service center's experience and exploration on psychological, creating a psychological support system by creating the local students and volunteers so that they can help others, their peer group members, the villagers. So, any query, any clarification?
Maybe one thing I can check in. Thank you, Dr. Mukesh, for the presentation. I was wondering that based on this experience, have you been able to work with the state government in terms of better preparation, any resilience? Because given that it's a Himalayan state, Uttarakhand remains quite vulnerable to these kinds of events, including now, as we've seen also in parts of the Northeast, glacial lake bursts are the other major risk. And with global warming, etc., we will probably see the likelihood of such events increasing. So has there been now at least better sensitivity and preparation at the level of the state government? And have you been able to work with them in any way in preparing for any future similar events?
Anand sir, that is actually after 12 years, one of the major the area which government has focused and worked out is about road connectivities. That has increased. Earlier, when we were having this medical operation during 2013, there was only one connected road, and that was been washed out. So now this link roads are been, that was one of presentation we give to DM Rudraprayag as well as our National Disaster Management Authority also. Link road are been now developed, link road, and that can be facilitating for any calamity. That is a still earlier when that one road is suppose from Haridwar towards this Kedarnath, main highway has been blocked, then it was all a kind of standstill. Now there are many off routes and closer route that has been developed as a part of this border road organizations. They have developed it. This is one of the major that in future calamity, it can be our medical activities and all that can even rush to that spot. And it has happened recently also. That is one of major development in that area. Thank you, sir.
Thank you,
One
Mukesh.
thing that I
That's
can
very
add,
good to know. Yeah, please go
Dr.
ahead.
Anand. Yeah, one thing I can add, like after we did this work of psychological support system during 2013 Uttarakhand flood. Thereafter, recently in Joshimath area, there had been landslide, and there we found that government took the initiative to mobilize the mental health professionals to cater the psychological need of the local people. So there is some amount of sensitization that has happened in that area, we believe. Thank you.
Thank you. Very useful to know. Yeah, I mean, I think the connectivity is certainly a big positive, though the challenge I think also has been with the construction of all of these bigger roads that in those eco-sensitive sections of the hills, that also brings its own risks associated with landslides, etc. But I mean, there are pluses and minuses, I think, with the development models that we talk about. But maybe, Dr. Prashanta, we can go to the next presentation.
Yeah. Hello, Dr. Anshuman Mitra.
Yeah, I'm here.
Yeah, Dr. Anshuman Mitra is a medical professional. He is being introduced before also, and he is the All India, the main person of this disaster care of medical service center. And he did his extensive work in uh, the Delhi, the Kisan movement, where by establishing the camp by medical service center, many psychological issues have been discovered, particularly the substance-related issue. So Dr. Anshuman Mitra would be presenting his
Thank you,
observation.
Dr. Prashanto. Thank you, Dr. Prashanto. Let us have the next slide. This is a social activity in managing substance use among the participants of Delhi farmers movement in India. So there's a The Delhi, capital of India, a farmers movement, participate, why they are participating and how success use comes in, and how is the social activity useful over here. These are the questions we have dealt over here. Next slide, please. Next slide. So what is the, hello, next slide, please. So let us go into the background of the thing, the Delhi farmers protest. So what was the crisis farmers were facing in 2020? New set of farm laws and issues on MSP, that is minimum support price, was being initiated by the government, by the central government. The government control was shifting to being corporate driven. The entire farming industry was being shifted corporate driven. There was a widespread fear among farmers and people for losing control and ownership of farmlands and produce from their grip to the large corporates. That was the crisis which was impending. So next, what happened? Next slide. What happened after that? There was, next slide, please. Am I audible? Sometimes I'm audible. Next slide, please. Yeah. So
Yes,
what was
yes,
the
you are
reaction
audible.
to that? What was the reaction to that crisis? There had been large democratic rallies conducted by farmers and citizens from different districts and state capitals of Punjab, Haryana, and other North Indian states over 5 months. Ultimately to the national capital in end November 2020. Large number of people camped outside the outskirts of Delhi. When they were stopped at the outskirts, they are marching towards the Jantar Mantar in November. There was a national festival over there. But they were stopped at the outskirts, at the outside in the Delhi borders, and large numbers, in lakhs, started camping outside the Delhi borders. So, next slide. Next slide, please. So they started camping in a new, no, previous one, sir. So a tent and trolley city, a new subject started developing. Hello? Hello, anyone speaking anything?
You continue. Dr. Mitra, you continue.
A new subject we found emerging in front of our eyes. We named it protest habitation. So they came in tent and finally came in trolleys, actually huge tractors, and they were tugging trolleys behind them and some huge lorries. They were covering them with tarpaulin, tripol, and taking them into tents. It was chilling cold at that time. But in course of time, it changed. I will get to it later. Next slide, please. So, what was the hazard? Next slide, please. Next slide. What was the hazard? What were the adverse effects of the crisis? The people had no idea of any public health or mental health challenge or crisis. The people had no such idea. What we observed in the social media was totally cut off. Only social media we found water cannons being charged in freezing Delhi cold. It was almost 2-3 degrees centigrade at the time. Pneumonia occurred in elderly people who faced water cannons and death. So, large gathering was restricted. A large gathering in a restricted zone itself is a public health challenge, and this is not accepted, not recognized in our system. Just you see the stampede recently in Mahakumbh and Prag and New Delhi station. See the IPL celebration in RCB, Chinnaswamy Stadium, Bengaluru. Just this is the example that there is no idea in our system how to address a public health gathering. Next slide. So, with this, in that cold, the movement, that gathering of people, lakhs of people on the Delhi borders. The Singhu border. Next slide, please, sir. Next slide. Tikri border, and later in Ghazipur border towards UP. So, sir, next slide, please. I should. So, casually, this is what I was telling, that with the changing of seasons, first that thin shades started coming because there was a lot of rainfall, a lot of storms, blowing away the tarpaulin sheets and all. And later, when the summer was coming, initially you can see on the top left that there's the thatch, bamboo structures. Then it was becoming Again, rainfall and something during that summer season, I started making building sort of thing with fabric, fiber, all these things. So, and then you will just see AC also. You can see an AC over here. So it was getting so hot in March, April, that it's not AC. Our concern was COVID was rising all over the country. That is the February and March of 2020. So just imagine. Next slide. Next slide, sir. So I'm putting an introduction to the problem. There are over 6.6 million drug users in the state of Punjab. Only one state, Punjab, has 6.6 million drug users, of which 697,000 are children below 18. The parliamentary panel report. So during the year-long farmers' protest in Delhi in 2021, from end of November to beginning of December 2020 to end of December 2021, Medical Service Center MSC set up base and rendered medical support to the massive congregation. They encountered the issue of substance use among mainly young section of participants. So we stumbled upon a problem. Just like this, we stumbled upon a problem which we were not prepared. We were not even aware that this problem exists. So next slide, please. So next slide. So to address the challenge of substance use, we took up the challenge. We took up the challenge because the very interesting dynamics I'll show you later. Networking and learning to extend the care. We organize workshops. Psychiatrists, mental health caregivers in North India who handle substance use and handle this population, they ultimately extend people network all of the states of North India, and we got the support from people, and we could organize workshops for our own volunteers who are non-mental health caregivers. We work in disaster, we know disaster mental health, but substance use mental health is very specialized, so we don't know. So next slide. So we had to learn, we had to integrate this new knowledge into our work and how we reach to the people. Next slide, sir. Sir, next slide, please. Sir, can I have the next slide, sir? Sir, please give the next slide.
Okay. Is it this one?
2, 3, no, 2, 3 slides are past.
Are we in the correct slide?
Go to the aims and objectives. Go to the aims and objectives.
Yeah.
Yeah.
So the aims and objectives, we developed this study in course of our work to assess the nature and impact of substance use among the participants of farmers' protest, to assess the impact in managing withdrawal symptoms, in minimizing or controlling intake pattern of the group and of the group dynamics. What is the dynamics in the group? It's a new culture, new sort of language issues, new sort of practices. That also we had to get into orientation. We used the slide, we used the open questionnaire. Next slide, sir. So next slide. So the methods we used, the study participants were the farmers attending, the farmers and general people also attending the medical camps organized by Medical Service Center. The study period is 1 year, 13 months actually, from beginning of December 2020 to almost end of December 2021. The sample size is 53,000 people who attended our clinics all over. How we did, I'll tell you. The study design, we used the unstructured questionnaire survey conducted by newly graduated doctors, nurses, and paramedical volunteers in the MSc base camp. Next slide. Next slide. So the unstructured questionnaire we used, just very simple, yes, no response. Do you use substances? If yes, of what type? How long have you been using? Days, months, years? Have you faced any problem during this engagement? Yes or no? Have you sought any help from others? Yes or no? Are you following instructions regarding substance use? Actually, what we found, youngsters were coming, age of 17, 20, 25, coming and asking for some particular drugs and some particular tubes. They call it tube, the diclofenac gel tubes. Later we came to know that the tubes they smear on bread to have as jelly, that is a sort of kick for them. And many of the ibuprofen, many Adnor, many brand names they were telling. Even brand names, since I don't use them, I didn't know those brands. I had to search out to find what are they. So then we stumbled upon, they have been using these things, just like so. So the methods used, the study site is a total of 273 base camp OPD days, 70 satellite camp days, and 35 mobile camps. So this is the network we used to get to the people, that 50,000 people, how we got to them. Through this network in Singhu border, in Delhi Karnal Highway from 2nd December 2020 onwards, behind what would later become the main stage. It was open on the road, huge, thousands of people walking up and down. There we set up the camp. I'll show you how we did it. And then the Tikri border, Delhi Rohtak Highway, survey on 6th December. Then we set up the base on 26th December onward at the Sridham Sharma metro station, below the metro station, under the metro corridor. And then satellite camp and Rohtak bypass. I'll show you this slide. So the formal inauguration of the base camp was done in Singhu border on 3/12. We started on 2nd, but the formal inauguration was done in the presence of all the farmer leaders over there and our volunteers. You can see the small tent in the right side column. You can see small tent behind. That was what we pitched. Just like sir. Then we started the base camp evolved into step-by-step multi-dimensional, multi-faceted center of attraction for the entire Kisan Andolon. There was OPD, there was pharmacy, a lot of hectic work in the day, a lot of hectic work throughout the night, just like sir. Networking and communicating and referring, and emergency only referral center, just like sir. Only referral center for the entire almost 10, 11 kilometer long campus in Singhu border. Just like sir. So, and the establishment of MSc base camp in Andhra Pillar we found in 26/12/2020. You can see we have set up the medical camp over there. And then people started coming, and this is in the middle of an industrial area. So not only people who are in the farmers movement, but even people who are very poor people who are hand to mouth staying in that area, they used to come while going to duty and while coming back from duty. We used to feed all of them. We are all inclusive. That is the strength of our organization. Next slide. So here we are setting up the, you can see a small tent in the middle of the rainfall. All of us are wearing these raincoats, and a very senior elderly person, one of the Kisan leaders in that area, it was almost 7 kilometers from the main road along the bypass. And we started clinic over here also, satellite camp and mobile camps. Next slide. So the service provided by Medical Service Center, consecutive teams of volunteer doctors, nurses, paramedics, and support volunteers of 17 states and union territories. They are providing all essential outpatient and emergency service to all farmers and people attending during the period. Entire this almost 30 months. Next slide, sir. We tried to provide, next slide. So what was it? OPD, you can see base camp, mobile and satellite medical camp, 24 hours emergency and referral services. We are monitoring prevalent health conditions by visiting and surveying the other borders. Learning to provide relief to individuals with substance use issues. Provide hygiene services. Training. Observance of special days to learn from the lives of the struggles of the pioneers. So this way we reached out to the people, we had a bonding with the people, just like sir. We had bonded with the people, it was part of the entire life, just like sir, just like. So the arrival of team, you can see just 4 people with small bags, and in my hand you can see that 9 kilo tent, 6-man tent. Then are coming and are staying. We are planning to stay there to start medical. That ignited interest. NDTV is going to come cover us. Next slide, please. So, and the satellite camp, you can see in the middle of torrential rain. We were conducting the camp. People were coming to provide us food, care for us. And then we started from the satellite camp. We had mobile teams going out again and sitting with the people over there. by their shanties. So by this means, we are reaching out, and the cleaning and hygiene services. We started on the left. You can see small steps. We are spraying some insecticides. Some since COVID was starting, some of the chemicals we are trying to use. Gradually, it became a way of campus life. You can see huge machines brought in and full gear, people clearing in gear. This became a way of life, just like. So we could influence the attitude, aptitude, and on the 25th day, and that is beginning of April, you can see the camps. Hundreds of people came to wish us. At that time, we had 200 OPD satellite camps and 30 mobile camps, and 14,000 patients by that time. This is just 5th April, and on 19th April, that total lockdown was planned again. So we could reach out, we could bridge, we could network all organizations. Next slide, sir. We could network all individuals, organizations coming together. We tried to face the media also. That informers rescue, these are doctors without borders, literally news covered by the statesman. Then even us young volunteers who are coming in, they are trying to talk to them why they have come. Even non-medical students, young students also came. And when on 1911, the day when the black laws were withdrawn by the government, there in the middle of the night, you can see the farmer leaders, myself over there. We are being, the NDTV is addressing us. NDTV was then still free media. Next slide, please. Next slide. So we used to link up. You can see there's the main stage I told later developed. We used to give public health talks over there. We used to make people aware of various health challenges, about hygiene, about sanitation, about various possibility of various epidemics, how to handle, how to begin. There was no epidemic outbreak over there. And there was fire. We addressed fire. The huge, beautiful teamwork we had to address the fire. And in the 12 months, you can see we are addressing them again, congratulating them, the students, youth, women, everyone who have been making this struggle for 1 year. So this reach out, we have the doctors not remain in the ivory towers. Next slide, sir. We have to reach out from the ivory towers, we have to reach to the level of the people, and even people congratulated us at the year of the ending of the 1 year. Next slide. And thus we could reach and we could bring. So what are the findings? The findings about 2.58% were users of alcohol, heroin, and opium. Actually, opium is different. Because opium is culturally very accepted in this entire North Indian state, and they have a community smoking. You can see here very beautiful hookah in the middle, and people sitting in a whole circle around them, and the hookah passes the mouth to mouth like that. So it is a normal culturalization, normal socialization for them. So opium normally they don't tell. Most of them were using these for months to years. Some of the participants presented with withdrawal symptoms and were on maintenance treatment, such as codeine sulfate syrup, diclofenac gel, they did by themselves, or even buprenorphine. But without backup, these were becoming lower level of substance use. So, next slide, sir. So the reason for withdrawal, this is the interesting part. Reason for withdrawal was their unwillingness to leave the farmers' movement. All consultants had advised against, do not initiate this escalation out here. But it was beyond our advice. They had voluntarily taken this challenge. Only they looked was for some relief during the pains of withdrawal. They were not getting de-addiction medicine too. Long-term substance users who were once on de-addiction regimen had at some time relapsed, demonstrating a positive attitude towards maintaining abstinence. They solved their own problem by through involvement and by engaging themselves in physical activities. We are just supporting them to ease their pain. They are not. Next slide. Next slide. So the discussion is, the study will sum up with this. The study showed that engagement in social activities can be an effective approach in the comprehensive management of substance use disorder. Social activity is not just some trivial hobby sort of thing, but link with their living livelihood, link with their being well. That's social activity. The approach to management of substance use disorders is multi-pronged. Substance use disorders should be managed in the context of social dynamics, not isolated. It cannot be treated only in the isolated de-addiction center. It has to be dealt in the context of social dynamics. So we conclude this study provided, you can see it was a relief work we went for, and then we converted that a part into a study, a unique approach of handling the menace of substance use. The study also reinforced that community involvement and group work can be an effective tool in handling individuals which might prove to be beneficial to the society. So that we conclude. Next slide. So I thank all of you for going through this. I thank JBI for this introduction and bringing people together on psychological first and mental health. This is a sketch of our tent and the students over there by one of our friends. So with this, I thank you all.
Thank you, Dr. Anshuman Mitra, for highlighting on important issue of addiction with respect to social activity and Kisan movement. We'll take up the discussion after the next presentation, and we are having Mr. Saptursi Basu Roy Chaudhuri. I'll call him a scientist. He is a researcher with CPHR, particularly working on both communicable and non-communicable diseases, with extensive experience, particularly focusing on public health related to climate change, environmental change. So he would be discussing about a scientific perspective of psychological first aid in response to disaster response and recovery. Before he begins, if Dr. Bhan would like to add anything. Thank you.
No, I think we can continue, Roy, and then we can maybe open up for discussions first then. But yeah, again, this will be a useful presentation to add to the discussions we've already had.
Yes, Mr. Saptursi.
Yeah, hi, Dr. Roy. Am I audible?
Yes, yes, absolutely.
Yeah, okay. Yeah, just give me a moment to share the screen.
Yes, you can make it full screen, it's visible.
Yeah, are the slides visible now?
Yes, yes.
Okay. Okay, first of all, I would like to thank Dr. Roy and Dr. Bhan for chairing the session. I would also like to thank JBI for giving us this platform. And I would like to thank CPHR especially for giving me the opportunity to talk about the role of psychological first aid in disaster response and recovery, reviewing the scholarly landscape, which is the title of the talk. Now, I think this will be a little add-on to the previous presentations that we have already listened to today, and all of them more or less touched upon various types of disasters that occurred in the past 20 years, posing significant physical and mental health challenges for the survivors. So in this presentation, so basically this presentation has been made out of our ongoing research on assessing the efficacy of psychological first aid, or PFA henceforth, in improving the mental health and psychological well-being of the survivors. So I would very briefly touch upon concept of psychological first aid, as most of you must have known, but for the broader audience. And this will be followed up by offering a background. What are the 5 essential elements and the 4 actions that are associated with PFA? Next, I will briefly talk about the protocol that we are currently developing as a part of our research, and that will be followed by a rapid review of 10 to 12 most recent studies that have occurred after 2010, covering or finding various aspects of this PFA intervention. Finally, I will point out some research gaps that have come out, and some concluding remarks will be provided at the end. Yeah. So as previous speakers have pointed out, exposure to disasters and traumatic events, they present some immediate challenges for survivors. This can include physical damage as well as mental damage. The aspect of mental damage is really dependent on the magnitude of the disaster. or the individual coping ability. So that's how the researchers have looked at the problem of psychological first aid, or PFA, because it has been pointed out that many individuals who experience severe stress, so they sometimes suffer from post-traumatic stress disorder and other mental health issues. So that brings us to the discussion of PFA, which has emerged as an essential component in responding to individuals who experience acute stress due to disasters or emergency situations. And now PFA is widely recognized as a preferred intervention of choice following exposures to such events. If I am to give you a very brief background, the concept is not very new. It was first introduced in the military during World War II, but especially after the attacks of 9/11, the concept of PFA really gained significance in the study of psychological support to survivors, disasters, and extreme events.
Dr. Rajiv Kumar, if you could kindly mute. Thank you. Yeah, please go ahead.
Yeah, thank you, sir. So since 2001, PFA is widely supported by disaster mental health experts and broadly recommended in consensus reports and peer-reviewed literature. It has been used by the National Center for Post-Traumatic Stress Disorder, the International Federation of Red Cross and Red Crescent Societies, and the American Psychological Association to denote programs that provide psychological care in the aftermath of traumatic events. Currently, PFA is being studied by the researchers, which encompass increasing number of different type of actions that are taught to responders, ranging from trained lay people to mental health specialists. Now, if we are asked who can provide PFA, it can be provided by mental health experts as well as social workers who are trained not only by them, but it can also be provided by first responders, volunteers, or even common people like us if they are skilled and trained properly. So a review of existing literature provides us this definition of PFA, which consists of a systematic set of helping actions aimed at reducing initial post-trauma distress and supporting short and long-term adaptive functioning. So the core actions really consists of 8 elements. The first is contact and engagement, which refers to respond to contacts initiated by the affected people. Second will be safety and comfort, that is aimed at enhancing immediate and ongoing support. Third is stabilization, which is required if the magnitude of the distress is really overwhelming or traumatizing for the survivor. Fourth will be information gathering. The role of that would be to offer practical help to the survivors. The next will be connection to social support, which is called for to reduce the stress or distress rather, with primary support persons such as relatives and friends. The seventh will be information on coping, which aims to provide the individuals with information, including stress reaction and coping. And the last core action would be linkage with collaborative services, which cater to informing them about the available services. So to present it in a different way, PFA is basically underpinned by 5 essential elements which emanated from the consensus conference that took place in 2004 by disaster mental health experts. And this has been summarized in a seminal publication by Hopfall et al. In 2007. So the 5 essential elements would be safety, calming, connectedness, self-efficacy, and hope, which together include the provision of information, comfort, emotional care, and hope. Now, if we are to briefly talk about the application of PFA in disaster settings, so as I previously pointed out, this can be offered by not only the mental health professionals, but also by first responders or volunteers if properly trained. They are typically delivered on site or in temporary shelters. The PFAs are aimed to ensure physical safety and helps to meet urgent needs such as food, water, shelter. The trained responders offer a calm, compassionate presence to reduce distress and foster trust, which is an essential element of PFA. Survivors are given space to express their feelings without pressure. Also, individuals are guided towards additional resources such as medical care, which we have seen in the previous presentations also, which is an indispensable part. Also mental health support or reunification services with friends and relatives. Also, PFA encourages survivors to use personal strength, social support, and practical coping strategies. And lastly, one of the previous presenters did pointed out that it is non-intrusive in nature. Under no circumstances it intrudes or pushes people to talk about or relive their traumatic experience. Now, if we study the existing literature, there are a few levels of evidence which they have used to, or studied rather, to identify the nature of the intervention. The first would be experimental and population-based studies, which include population-based randomized prospective studies or meta-analysis. It also consists the systematic review of multiple higher evidence studies with substantial effects. Seconds are smaller experimental or epidemiological studies, including large non-population based studies or randomized prospective studies with smaller or less significant effects. Third and fourth levels of evidence would be prospective observational analytical studies and retrospective historical observational or analytical studies in a controlled, non-randomized and cohort environment. The difference being prospective observational studies bring the study to forward, whereas the data is collected as and when the events occur, whereas retrospective or the historical observational studies typically use the existing data to assess the outcome or impact of the previous disasters. The next level of evidence is large or descriptive studies, typically qualitative in nature, and use cross-sectional ecological case series and case reports. The next level of evidence is small descriptive studies, again using cross-sectional ecological case series, case reports. It also uses animal studies or mechanical model studies using non-human being or non-human being subjects. Next, peer-reviewed articles are studied, which include state-of-the-art articles, review articles, organizational statements and guidelines, editorials or consensus statements. Non-peer-reviewed published opinions or gray literature, as we call it, include textbook statements, official organizational publications, guidelines, etc. And finally, the rational conjecture is included in the level of evidence, which includes common sense, common practices accepted before evidence-based guidelines. So considering the levels of evidence, what we are basically doing is we are trying to build a protocol for a systematic review that will aim to assess the efficacy of PFA in improving mental health and psychological well-being of individuals exposed to disasters or potentially traumatic events or PTEs in low and middle income economies. Because when we studied the existing literature, it definitely emerged that most of the studies focused on the PFA intervention in developed economies as compared to less developed economies. So that came out as one of the motivations for developing the protocol. The inclusion and exclusion criteria we will be following is that the review will include all the studies that evaluate programmatic outcomes of PFA in LMICs published in English since 2010. Studies that do not analyze a programmatic outcome or not in the context of LMIC will be excluded. We will be following the JBI methodology for systematic review, and electronic databases such as PubMed and other databases will be searched for peer-reviewed papers following the inclusion and exclusion criteria. It will first include a screening of titles and abstracts and later on full text screening. Finally, the results for each study will be presented narratively by outcome and intervention components. Now, let me just briefly present the study findings of a few studies that was conducted post 2010. So this is not a systematic review, but rather a rapid review of the study findings of few papers. So the findings have been placed alphabetically. So, and as you can see, the first and second, both of those studies took place. The setting was a developed country. The first is in Australia, second in United Kingdom. The population consists adult hospital staff, mental health facility for the first one, and adult hospital staff and acute hospitals for the second one. They respectively studied the PTE of occupational violence and COVID-19. One is qualitative in nature, the other is quantitative. None of them used a control group, but most importantly, both the studies found that the PFA intervention was supportive. It was able to improve the mental well-being, and it was useful in normalizing reactions of the victims to the potential traumatic events. The next two studies again the setting was in one in United States, the other was in Canada. One studied the underage population in urban and rural areas. The other studied children aged 2 to 18 years in urban areas again. The 2010 study by Kine et al. Took into consideration the disaster of Hurricane Katrina displacement, while the second one studied asylum seeking. One is in quantitative in nature, the other qualitative. Again, no control group was considered. The first study found that PTSD symptom slightly improved because of PFA intervention, and the second study found fostered emotional safety and sense of normalcy and new connections. The next two studies again use the setting in USA. In one study, the population consists of undergraduate students in urban area. The other consists of adult population, and the location was not specified. The first study did not particularly consider any disaster. So, and the second one considered personally relevant stressful event. One is quantitative. Both of these studies are actually quantitative in nature, and they actually used control group. The first, a group conversation, and the second, a social acknowledgement. Now, the main findings of these two studies are that anxiety symptoms are negative and positive affect improvements compared to the control group. The second study also found the anxiety symptoms and mood improvements for the group that was intervened compared to the control group. The next study was Ironson and et al., published in 2020, where the age group was unspecified and the population mainly belonged to the urban area. It considered any disaster or PT, not any particular event. Using a quantitative approach, they considered a control group of EMDR, which denotes eye movement desensitization and reprocessing, administered stress management with a trauma focus. And the main findings of this study is that PTSD, depression, and trauma-related thoughts and beliefs were improved in the intervention group as compared to the control group, but with slower rates of improvement. The next two studies took place in Japan and United States respectively. The first took into consideration the population of the nurses who served COVID-19 inpatient ward, and the second considered the population of adult crime victims and law enforcement agencies. Both of these studies were quantitative in nature. The first one did not use any control group. The second one used a control group of usual services. The findings are that psychological distress, sleep disturbance, and appetite, these symptoms were improved as a result of PFA intervention. And the main finding of the second study was that global functioning improvement compared to the control group, no improvement in psychiatric or adaptive functioning. The next study was conducted by Meir et al. In Israel, considering underage population in urban areas who faced the threat of deportation. The research approach was quantitative, and they used a control group of the same age group, and it's mentioned here. The main findings is that improvement in anxiety and depressive symptoms compared to control, no change in depressed mood, aggressive communication, or hyperactivity. The last cited study would be Ramirez et al. In 2013 in United States, studying the behavior of adolescent population in urban areas who faced the individual trauma of being a victim of flood. It used a quantitative approach, did not use any control group, and the main finding was that improvements in depressive symptoms and total social support, no changes in PTSS. Also, there is another study by Schaeffer et al. The country was Gaza. The population consisted of adults and adolescent population in urban area who have been or who were victims of political conflict and war. Qualitative approach was used with no control group. They found that contribution to safety, reduced distress, applying calming practices, and sense of control and hopefulness regained among the victims because of the PFA intervention. Now, after citing these studies, if we are to analyze the study findings, in summary, all the cited studies reported improvement in mental health outcomes, which is the whole point of studying the impact of or assessing the effect of PFA rather. 4 studies found reductions in anxiety and depressive symptoms. 4 studies measured symptoms of PTSD and reported statistically significant reduction in it, except one. 2 studies reported mood scores, with one finding statistically significant increase in the score and the other finding non-statistically significant improvement. Among the studies which undertook a qualitative approach, PFA was shown to enhance safety, reduce distress, and strengthen social connectedness, promote emotional regulation, and support a sense of control among both youths and adults. Now, as a part of our effort of developing the protocol for the systematic review, we were able to identify certain research gaps, and some of these have also been cited in the existing literature, which is that imbalance between widespread support for PFA and the limited availability of outcome-based evidence due to lack of empirical outcome data. This gap has been pointed out by a number of researchers, which basically underscores the need for more empirical data or outcome analysis. Next is limited randomized controlled trials, as most evidence is based on observational studies. So as you can see, out of the studies that I cited, 12 of them, only 2 of them used an RCT trial. The rest of them were mostly observational studies. The next gap was identified as unclear mechanism of action about which components of PFA lead to positive outcomes. Now, since I already talked about the 10 core functions and components, so it underscores the need for analyzing each component in detail and assess and see which component lead to most positive outcomes. Also, there is a lack of standardized training and delivery methods, which makes it difficult to compare results across settings. And more research is needed on how PFA should be adapted for different cultural groups, age groups, and disaster contexts. The next research gap was identified as limited data on PFA's effectiveness for the vulnerable population, especially children, older adults, the disabled people, and those who already developed or showed symptoms of mental health conditions prior to them being victim of the disaster per se. Also, insufficient evaluation methodologies of PFA interventions were identified that creates a need for validated tools to assess the quality and impact of PFA interventions. Also, few studies examined how well PFA training prepares providers and whether interventions are delivered as intended. So again, more research in that area is warranted. Also, insufficient research on how PFA fits within the continuum of care and links to other mental health services. And finally, the ethical implications of deploying non-specialists to provide PFA in high-stress environments are a little under-researched or under-explored. So considering these research gaps, all of these give us a future, or rather room or scope for future research where our future studies can head into. And to give you some concluding remarks, PFA is recognized as a primary early intervention strategy by mental health experts and international organizations. International treatment guidelines for PTSD and disaster response, it definitely recommend PFA as a frontline support measure. It prioritizes on 5 elements, as I pointed out before: safety, calming, connectedness, self-efficacy, and hope, which are the key protective factors post-disaster. Now, the existing literature definitely supports the role of PFA as a low-intensity intervention for reducing initial distress and promoting adaptive functioning. However, the review of literature also indicates certain methodological and empirical gaps, resulting in difficulties to advocate its effectiveness, which definitely creates a room for future research. And finally, additional evidence is needed to validate the growing use of PFA across diverse settings. So that was all from my end. Thank you.
Thank you. Thank you, Mr. Saptursi, for a comprehensive presentation on the current research understanding in relation to PFA. Now, this session is open for discussion, query, and clarification. Dr. Bhan.
Dr. Ray, question in the chat box from Dr. Yadav about the policy changes for international and national level for disaster preparedness and response and the usefulness of digital technology in telemedicine. If someone can respond. Thank you.
I'd like to add a few words.
Yes, Dr. Mitra.
The policy matters. Basically, first, the basic truthfulness has to be there. Policy is there. Disaster Management Act is there, and we saw that it was clamped during the COVID period, and changes also in the total administrative system was. But basically, what we find, unless the scale of the problem is accepted, it is no one is saying someone's fault. But unless the problem is accepted, like we found in all the reports, in the report by Weinhardt landslide, the Kedar Ghati, all we found that there's missing a lot of problems are told. Like where, if you remember the slide, walking in the umbrella, rain was coming in. That was actually covered on the right hand side. It was entering that Mundakai area. It was one story, just on the right hand side, the pond was going up to 3-story buildings were there, and now it looks like a stream of stones has come down the slide. So that 1,000 people went to bed the last night, and now they are identified as missing. And this missing is never identified. In all disaster, you will find how large number of missings are there. And unless the identification of dead is there, identification of the nature of disaster is there, downscaling of the problem will not be able to address it. Normalcy for almost probably Bhan will also agree with me, almost more than 40 or 50% of our population normally they are living in disastrous health conditions. So these issues, but some policies might be brought on paper, but on ground level, unless the basic application is there, we cannot address issues by just policy matters. The application of the professional committed people, the linking up with the population system at large at all levels, that can bring a change. And that is why when services are trying to start even a course, the point which was mentioned by Saptashi, that non-uniformity of care, non-uniform understanding, though PFA is to be given by laypersons, but they have to be trained for that. That really is not there. So these to help in this, we are working towards the online course for basics and then advanced in PFA. So we need input also for that. So this collective approach by professional individuals and committed professional groups is very important. That's all.
Thank you, Dr. Mitra. About the second part of the question that is asked by Mr. Shubham Yadav about the digital technologies such as telemedicine being integrated into disaster medicine response, particularly for psychological first aid delivery. First of all, psychological first aid is not to be provided by the professional. It is a grassroots level, community-based level of intervention, low intensity intervention to be provided by the local people, local volunteers. So obviously the role of the telemedicine doesn't come wherever we think about implementation of psychological first aid, but the professionals are supposed to give the necessary training of psychological first aid to the volunteers so that those can be applied. So there obviously the digital technologies can have significant role in providing training. There are some online platform where the similar training is available. Medical Service Center is also conceptualizing as some the training module that would be available using digital technologies on psychological first aid. So that about the training, it is possible, but implementation of the psychological first aid in the field using telemedicine is not possible because it is to be given by the people, for the people. Anything Dr. Bhan would like to include?
Yeah, no, I think that's an important point also, because sometimes we tend to think that psychological responses, or in fact any kind of a mental health response, requires a specialist. And most evidence which has been generated now indicates that that is a problem because we have such an acute shortage of specialists. And there is enough evidence which supports the fact that this a lot of mental health needs, including in the disaster response area, is likely that it's likely that we can provide that by working with communities and even by non-specialists, as long as they are trained and then there is supervision, etc. So that's where I think the last presentation was also speaking about the fact that perhaps we need more evidence specifically in the disaster response space. But generally in mental health, task sharing approaches have been shown to be efficacious, feasible, acceptable by and can bring about a lot of change, because there is such a gap in terms of mental health provisioning as it is within our health systems, that any models that we can develop and evaluate which make mental health accessible becomes important. But of course, when you have disruptive situations like disasters, and it becomes a challenge. But if we can pre-plan and have some mechanisms to ensure that such services can be provided, then it can be certainly very useful for communities. Relying on specialists, I think, is always going to be a challenge, given the paucity and acute shortage of specialists that we have in both India, South Africa, and many other similar countries.
Even for the mental health professionals, if they are not prepared to deliver psychosocial support system in the disaster area, we have witnessed during 2013 Uttarakhand flood that one of the mental health professional who visited Rudraprayag just out of emotion to volunteer in the field. And we suggested some of the precautions before entering the field. We suggested about the how to take care of the self, whether she slept well before going there, whether she had taken food. And she said that I am here to serve the people, not to have food, not to sleep. And so we couldn't stop her. And within couple of days, she started developing some psychological reaction within herself. And she started disrupting the camp environment because she was suffering and she had to send back. So sometimes if you are not prepared, even as a mental health professional, to work in the disaster field, to work on the psychological aspect, even it can create a vulnerability for ourselves. That is also important. Anything from South Africa? I would like to share your understanding on this, if some of you are having any experience.
A lot of participants are there from different countries in Africa and also other countries of Asia. So if there is someone puts any question or any observation also, that would be very helpful for us. So Basu.
I think it's extremely beneficial to listen to all the presentation, put it together, and what you have noticed, whether it's a man-made or natural. I think the need for a coherent disaster management strategy, that initial shocks and what happened, and I think then aftershocks. And I think it is definitely it prolonged, as you heard from Mrs. Bogoshi, that even after 4 years, we are still not back to normal. And I think it shows the necessity of how, when a disaster happens, how to respond to it. And Dr. Ray's comment about the digitalization, yes, it's important, we can use it, but still there is a human touch is necessary. That high touch, high tech type of environment, I think it is still relevant. noticed that we are running a bit late, and we apologize to the audience. So maybe it is high time to hand over to Dr. Paramita to close. But I mean, we should continue with the discussion. We should not stop it here, because I think it is just the beginning of the discussions. And my suggestion would be that we are actually recorded this, and we will share both in YouTube and Facebook. Plus, we'll put it in the drive. So please do share, colleagues, with everyone. And what I would suggest, that because we are from different centers, different parts of the country, even people are joined from China and other parts of the world, which is very exciting for us. And I think we need to organize now local discussion around it from this event, and see that how people best can participate. And we are looking forward to it. And I know our colleagues from the CPHR are avid writers, and we are going to synthesize this and share with all the presenters, so that we can write a synopsis and a conference report, and we will try to publish it as well, so that with permission from all the presenters, if that's okay with everyone. And we will contact individually to say who gave the permission, so that we can able to share that and write it up as a conference report. Because we only got around over 200 people attended it. At the end, we counted the head, but there are many people, I think, who could benefit, who couldn't join us. But thank you again, and we will hand over to Dr. Paramita.
But there is just one point. Since people who have registered, they have shown their interest in this topic. If we could circulate from the office some fundamental questions to which they could respond, then we could get a lot of specific inputs regarding challenges faced in different settings, different conditions, different climates, different countries. That would enrich our knowledge much more. So if that can be done, I think that will help us in our developing these concepts.
Sure, sir. That so thank you everyone for staying with us. And on behalf of the Center for Public Health Research and the JBI Center for Evidence Synthesis and Implementation in Indigenous Health, the Ekurhuleni Center, the JBI Center, and the Medical Service Center and University of Pretoria, I take the privilege of delivering the vote of thanks for the enriching webinar on disaster medicine and psychological first aid, lessons learned from India and South Africa. First and foremost, I extend my deepest gratitude to our distinguished speakers and presenters who took the time to share their invaluable experiences, case studies, and insights, from the Balasore train accident in India to the hospital fire in Johannesburg, from the Wayanad landslide to the Uttarakhand floods, and from community mental health responses to scholarly reviews of psychological first aid. Each contribution today broadened our understanding of the multidimensional nature of disaster response. Your work really inspires us to act with urgency, sensitivity, and strategic foresight. A heartfelt thank you to our session chairs, Professor Jani Hugo, Dr. Anshuman Mitro, Dr. Prashanto Roy, and Dr. Anand Khan, for guiding the discussions and offering meaningful reflections throughout the day. I would also like to extend our sincere appreciation to Professor Zoe Jordan, Executive Director of JBI, for setting the tone with her powerful introduction and continued global leadership in evidence-based healthcare. We are grateful to our colleagues at JBI, both in South Africa and Australia, for their enduring support and collaboration. Our warm thanks goes out to Dr. Devashish Vasu, Dr. Nirmala Mukherjee, Dr. Tarun Kumar Mondal, and Professor Jayati Kusari Vasu for providing thoughtful overviews of our respective institutions and for strengthening the spirit of international cooperation. To our audience, academics, practitioners, policymakers, and students from India, South Africa, and beyond, thank you for your time, engagement, and commitment to improving disaster preparedness and community resilience. Your presence has made this webinar truly dynamic and meaningful. I would also like to acknowledge the tireless efforts of our organizing teams across the institutions who have worked behind the scenes to ensure the seamless execution of this event. Your coordination and dedication is truly appreciated. As we close today's session, let us carry forward the spirit of collaboration and learning that today's discussion embodied. Let us continue to work collectively across borders and disciplines to build resilient health systems that uphold both physical and psychological well-being of our communities during crisis. Once again, thank you all for joining us. We look forward to a continued dialogue and shared efforts in strengthening the disaster response and mental health integration in the global health frameworks. Let's stay safe, stay connected, and thank you once again. Thank you all.